Hello my dear curious and studious students of surgery, myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome my dear students in my surgery lecture number 114, that is the neoplasms of the salivary glands. In this lecture we will explore the neoplasms of the salivary glands, classification of the salivary tumors, pleomorphic adenoma, that is the mixed tumor, carcinoma of the parotid gland, treatment of the malignant tumor, parotid fistula, silolithiasis of the submandibular salivary gland and the submandibular calculi. All these points are covered in this lecture. Now start with me the neoplasms of the salivary glands. Approximately 75% of the neoplasms of the salivary gland occurs in the parotid glands. In the parotid glands, 80% of the tumors are benign, and of these 80% are the pleomorphic adenomas. The remaining of 20% is composed of definite carcinomas along with the mucoepidermoid and acinic cell tumors, which are generally considered to be the cancers with variable aggressiveness. About 15% of the salivary tumors occurs in the submandibular salivary glands. Of these, 60% are benign. Of the benign tumors, 90% are pleomorphic adenomas. Now the classifications of the epithelial tumors. A is the epithelial tumors, B connective tissue tumors, and C is the metastatic tumors. A epithelial tumor, benign and malignant. Benign is the pleomorphic adenoma, mixed tumor, oxyfilled adenoma, papillary cyst adenoma, lymphomastosome, that is the Warthin's tumor, and basal cell adenoma. And the epithelial tumors, the malignant tumors are the mucoepidermoid carcinoma, adenocystic carcinoma, acinic cell adenocarcinoma, papillary adenocarcinoma, squamous cell carcinoma, undifferentiated carcinoma, and carcinoma arising in the pleomorphic adenoma. And second group of the neoplasms of the salivary glands, that is the connective tissue tumor, arises from the connective tissues, benign, hemangioma, lipoma, neuruloma, fibroma, and malignant connective tissue tumors are the malignant lymphoma. Benign tumors, as mentioned above, may turn malignant. These are the classifications of the neoplasms of the salivary glands. And C is the metastatic tumors. Tumors mostly affect one of the three major salivary glands. Tumors of the minor salivary glands are encountered most frequently in the palate. The upper lip is the second in frequency. These tumors are occasionally seen in the nasopharynx, larynx, bronchi, and nasal sinuses. Now, the first entity of the neoplasms of the salivary glands is the pleomorphic adenoma, which is the common, and that is also called as the mixed tumor. This is the commonest tumor of the major salivary glands, and its marked feature is histologic diversity. It is called mixed as there is a cartilage besides epithelial cells. The sites of this pleomorphic adenoma are, though this tumor usually occurs in the major salivary glands, yet it may occur in the salivary glands of the palate, upper lip, and the buccal mucosa. Tumors of the minor salivary glands, including mixed tumors, are encountered most frequently in the palate. The upper lip is second in frequency. This tumor most commonly occurs in the parotid, and about 90% is seen in this gland. 7% is seen in the submandibular glands. In the parotid glands, the commonest location is the tail of the gland. Now the pathology of the pleomorphic adenoma is, the pleomorphic adenoma is basically a benign tumor. Recurrence rate, which are reported to be as high as 45%, was mostly due to the fault in the surgical techniques in the form of the simple enucleation, which was often used earlier. It must be remembered that the tumor capsules, which may be seen from over much of the area, is often incomplete. Careful examination reveals the presence of tiny exudations which project from the lobulated surfaces of the main tumor. It is from these that the recurrence develops sometimes years after the treatment of the mixed tumor. Dear students, here is the image on your screen you are watching. This is the pleomorphic adenoma of the parotid gland. And the second B image showing the CT film is clearly seen the pleomorphic mixed tumor. Now the clinical features. First is the age. It is more frequent around the 40 years of age, but it is also seen in children. Slightly higher incidence in women has been noticed. Examinations, first is the site. The typical site of the tumor is below the lobule of the ear. The tumor gradually takes the position of the inferior part of the parotid gland just posterior and superior to the angle of the mandible. Temperature and the tenderness. The temperature and the color of the overlying skin are normal. Tenderness is conspicuous by its absence. Shape. The tumor tends to be the round or oval when it is small. As it grows bigger, it becomes lobulated. Next examination type is the surface. Its surface is smooth, sometimes it is the basaltate and is occasionally crossed by the deep furrow. Age, the margin is quite distinct. Consistency, it is a firm and rubbery to feel. Variable consistency is a marked feature of this condition. Fixity, it is the neither adherent to the skin nor to the masseter muscle. Involvement of the facial nerve, even when the tumor is a huge one, the facial nerve is not involved and remains free. Involvement of the facial nerve indicated by the paralysis of the involved facial muscles indicated infiltration of the nerve, and it is sure indication of the carcinomatous change in the pleomorphic adenoma. Next examination is the cervical lymph nodes. These are not enlarged. Examination of the inside of the mouth. This is the only required when such tumors arises from the deep part of the parotid gland. This is an extremely rare incidence. In these cases, the tumor pushes the tonsil and the pillar of the feces towards the midline. Now, the investigations of the salivary neoplasms. At present, the CT and MRI scanning are the most helpful imaging technique for parotid and mandibular tumors. These imaging techniques, particularly MRI, indicate accurately the borders of the tumors and indicate whether it is a circumscribed benign tumor or diffuse invasive malignant tumor. Moreover, the anatomical relationship of the tumor with surrounding structures will also be identified by the MRI technique. Fine needle aspiration, that is the FNA biopsy, is much better than open biopsy. It is said that provided the needle gauge does not exceed ATG, there is no risk of the seeding of viable tumor cells. About accuracy, there is a question mark through the advocates of the technique claim a very high accurate rate. Open incisional biopsy is not recommended for the neoplasms of the major salivary glands. An incision into the poorly encapsulated tumor will spill the tumor cells into the surrounding tissue planes, which will lead to multiple local tumor recurrences even many years after the surgery, unless they are subjected to the radical postoperative radiotherapy, which should be avoided in the management of the benign diseases. Now, the treatment of this pleomorphic tumor is, this tumor is radioresistant, so excision is the treatment of the choice. There is no place of incisional biopsy. Though fine needle biopsy has been advocated by a few surgeons, biopsy of the parotid carries a risk of the damage to the facial nerve. For tumors of the minor salivary glands of the palatal region, preoperative biopsy is the must. Where service of expert cytologist is available, fine needle aspiration biopsy can be performed. This type of the aspiration biopsy, guided by the computed tomography, that is the CT scan, is a valuable mean to detect the nature of the deep lobe tumors. Enucleation is followed by the recurrence is as many as 50% of cases, as there are tumor extension outside the capsules of the tumors within the normal salivary tissues. Attempt at excision of these tumors with a cut of the surrounding normal tissue is also accompanied by injury to one or more branches of the facial nerve, so this treatment did not receive wide acceptance. Superficial parotidectomy is the treatment of choice. This operation is also known as the Parotid operation. In this operation, after isolation of the facial nerve and its branches, the facial portion of the parotid glands is dissected from the underlying tissues and removed with the tumor inside it. This operation brings down recurrence rate to minimum, as also assures against injury to any branch of the facial nerve. The excised mass is now sent for frozen section if a low-grade malignant lesion such as an acinar cell adenocarcinoma, an adenoid cystic carcinoma, or a low-grade mucoepidermoid carcinoma is detected. The remainder of the gland should be removed, probably with the sacrifice of the facial nerve. If a high-grade malignant lesion is detected, that is the anaplastic adenocarcinoma or commonest cell carcinoma, a radial neck dissection should be accompanied by removal of the remainder of the gland. If the tumor is a simple pleomorphic adenoma, no further treatment is required except a regular follow-up. Majority of the tumors of the salivary glands are radioresistant. However, the more malignant lesions demonstrate the considerable sensitivity to radiotherapy, and this treatment may be considered as adjuvant to excisional surgery when required. In case of the submandibular gland neoplasm, the whole gland is excised with the particular care of to preserve the lingual or hypoglossal nerve. In case of the palatal nerve growth, an incision is made over the tumor, the periosteum is raised from the bone and the greater palatine vessels are mobilized. Clamp diatherma is beyond the tumor. The whole tumor is excised. The palatal bone may need to be sacrificed when it is invaded by the tumor clinically or radiographically. Now, the carcinoma of the parotid glands, regardless of the pathological variety, carcinoma of the parotid gland is being considered in this section. Age. The patients are usually over 50 years of age. Sex, males and females are equally affected. Symptoms. The most common complaint is rapidly growing swelling on the side of the face. The swelling may be painful. Pain is more felt during the movement of the jaw. Pain may radiate to the ear, to the face or to the neck. There may be a history of the painless lump for quite a few years, and recently the swelling has suddenly increased in size. Now the examinations site, it is in the parotid region. Temperature and tenderness, the overlying skin may be the somewhat warm. When the skin is infiltrated, it may look reddish blue. Tenderness is usually not present. Size and shape, carcinoma is usually of big size and it grows bigger within a short time. It may be of any shape. Surface, it is irregular. Consistency, the mass is usually hard but may be firm. Fixity, this swelling is often fixed to deeper structure. When the masseter is made taut by clenching the teeth, the swelling becomes fixed and cannot be moved along the line of the fibers of the masseter, but slightly sideways movement may be present. The skin may be free, but a few carcinomas shows a tendency to infiltrate the skin. In that case, the skin cannot be lifted up by the tumor. Regional lymph nodes are often enlarged and hard. Facial nerve often involved by carcinoma of the parotid. This will lead to the paralysis of the facial muscles. General examination, in case of few carcinoma, blood-borne metastasis may be present, particularly to the lungs. Now, the treatment of the malignant tumors. Surgery is the main treatment, though a few carcinomas like squamous cell carcinoma and the cylindroma recurrences may be treated by the radiotherapy. When the tumor present with clinical signs of malignancy, a fine needle biopsy is almost always performed if the lump is easily accessible. In case of the relatively inaccessible growth, an open biopsy is performed for frozen section during the operation, followed by the radical excision. Total peritodectomy with sacrifice of the facial nerve should be treatment of choice, particularly in case of the low-grade malignant lesions such as the acinar cell adenocarcinoma, adenocystic carcinoma, and low-grade mucoepidermoid carcinoma. In case of higher-grade malignant lesion, that is the high-grade mucoepidermoid carcinoma, undifferentiated carcinoma and squamous cell carcinoma, radical neck dissection should be accompanied by the complete peritodectomy. In a few cases of low-grade malignant lesion, one may try to save the facial nerve along with total peritodectomy through the technically it is difficult. Local recurrences should be treated by radiotherapy. When complete removal is not possible, superficial peritodectomy with radium implantation should be the treatment of choice. When the tumor is completely fixed and irremovable, only palliative deep X-ray therapy is advised. The facial nerve, which is sacrificed during the operation, may be grafted using the great auricular nerve. A few immediate reconstruction techniques have been used when the facial nerve grafting is not possible. Now the radiation therapy. If the surgeon feels that there is a residual cancer after radical resection, or if the pathologist reports cancer is extending to the margins of the resection, in such cases the post-operative cobalt therapy should be initiated as soon as the satisfactory wound healing has been obtained. Other advanced parotid cancers that are clearly not resectable may be controlled for many months by appropriate X-ray therapy. Now the chemotherapy. In occasional circumstances, the methotrexate or 5-fluorouracil therapy may cause limited regression of the malignant neoplasms of the parotid or submandibular gland, but its efficacy is not established for long-term palliation. Infusion with the cyclophosphamide, that is the cyclozan or endoxan, by retrograde catheter into the superficial temporal artery has produced marked regression in certain cases of advanced parotid carcinoma. Now, the parotid fistula. A parotid fistula may arise from the parotid glands or the parotid duct. Such fistula may be internal when it opens inside the mouth or external when it opens the exterior. Causes of the parotid fistulas may occur from the penetrating injury, particularly by glass sphincters, rupture of the parotid abscess, inadvertent incision for drainage of parotid abscess, complication of superficial parotidectomy. Now the clinical features of the parotid fistula are: the main complaint is an opening in the cheek with discharge. On careful questioning, it will be evident that the discharge comes out only during the meals. There may be excoriation of the neighborhood skin. Dear students, here is a good image on your screen. You are watching there, that is the parotid fistula, cutaneous parotid fistula. Now the investigations should be made. A cyclogram should be performed with watery solution of lepidol. This will give an indication whether the fistula is in relation to the main ductule or to the gland. Now the treatment: when the fistula is connected with the main duct, the reconstruction of the duct of Neumann's or Seabrook's operation should be performed. In this technique, one polythene catheter is passed through the parotid duct opening in the mouth in the retrograde fashion into the parotid duct up to the fistula. Another probe is introduced through the external fistula. A horizontal incision is made on the cheek. The ducts are dissected and the divided ends are identified and made free. The catheter wire is passed into the distal and proximal ends of the duct. It repairs without tension as possible as the ends of the divided ducts are slit longitudinally and then joined by the oblique suture line to avoid the stricture. Suture is performed by using 6-0 silk and Dexon or Prolene, which are placed in the submucous coat of the duct interruptedly. If reconstruction fails, the auriculotemporal nerve, which carries the secretomotor fibers to the parotid gland, is dissected. If the above method fails, complete parotidectomy is advised and preserving the facial nerve. Now the submandibular salivary gland, that is the silolithiasis. Salivary stones are more common in the submandibular salivary gland than in the parotid glands because the saliva of the mandibular salivary gland is more viscid and saturated in the calcium salts. Such stones develop more frequently within the ducts of the submandibular gland, that is the Wharton's duct. Less commonly, the calculi may occur within the gland substances. Etiology: the pathogenesis of the calculus formation is unknown. It has been suggested that the chronic inflammation may cause the inspission of the saliva in deposition of the calcium salts. That retention of the secretion may cause calculi formation. Such retention is more common in the submandibular salivary gland as the duct has a very curved root and the retention from the superficial lobe goes up and reach the submandibular duct through the deep part, which is not a dependent drainage. Dear students, here is a good picture showing the silolithiasis. The arrow shows the calculus in the submandibular duct and caries tooth is also there. This is the advancement of this image. Now the composition of the stone. A salivary gland calculus is composed of the cellular debris and mucus in the center, but the main content is the calcium and magnesium phosphate. Such combination is found in tartar of the mouth. Now the clinical features of the silolithiasis. Painful swelling during the meals is the most important symptom. Such pain may be preceded by the salivary colic. When this history is forthcoming, the patient should be given some lemon juice and swelling can be produced. At this time, if one orifies the affected duct, it shows little or no ejection of the saliva. Now the submandibular calculi. Age: majority of the patients are young to middle age. This condition rarely seen in the children. Sex: males and females are almost equally involved. Symptoms: the main complaint is pain and swelling beneath the jaw just before and during meals. Both the symptoms last throughout the meal. After certain period, the pain and the swelling gradually subsides. Some pain and swelling may persist. Some patient may give a typical history of colic just before the meals. Some residual pains and swelling beneath the jaw may be the constant complaint. Some discomfort or swelling may be complaint of in the floor of the mouth. Patient may be able to relieve his symptoms by pressing on the glands. On the other hand, such action may lead to ejection of false tasting fluid in the mouth, purulent saliva. Patient may give previous history of similar symptoms on the other side of the face. Dear students, here is another image showing the submandibular silolithiasis. Calculus in the submandibular duct is clearly seen, perforating the floor of the mouth. Now the treatment. All cases should be x-rayed before they go to the operation theatre to locate the exact position of the stone. First is a stone in the submandibular duct. If the stone is palpable near the orifice of the duct, it can be removed by an incision made directly over it through the mucous membrane of the mouth. The stone is steadied between the thumb and the index finger. The overlying tissues will be infiltrated and local anesthesia should be given. An incision is made directly upon the stone and which is extracted with a small scoop. Second is the stone in the submandibular gland. Excision of the salivary gland is advised. Other indications for excision of the submandibular glands are, and these are the when the gland is chronically inflamed, when the gland is the site of the stone formation, any tumors of the gland, secondary carcinoma of the submandibular lymph nodes. These are the other indications for excision of the submandibular salivary glands. Dear students, here is the end of our surgery lecture number 114, that is the neoplasms of the salivary glands. Thank you.